hipsters, hippos, hippies. No, even better, it's our own marvelous hip. Tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Staying mobile is more and more important as we age. Our hip joints carry a significant burden and do it amazingly well. But when problems do develop due to normal wear or maybe a fall, it can affect not only walking but our general health and quality of life. There are treatments designed to help restore movement and reduce pain all the way to a full joint replacement. First, let's take a look at this week's Prairie Doc quiz question. 1 in 5 people 65 years of age or older die within a year after their hip fracture. True or false? 1 in 5. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of our essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson, who will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. And I have to say, right now, our phones aren't working right now, so hold off on your calls until I give you the message that the phones are working. Joining us tonight is Dr. Jeff Kalo with Core Orthopedics, Avera Medical Group in Sioux Falls, South Dakota. So tell us a little bit about where you're from originally, Jeff.
I grew up in southeast Michigan, between Flint and Detroit. Grew up a Michigan State fan, and
you're a Michigan.
I'm a Spartan fan who's having a tough year this year in football. Left there and went to medical school in Missouri. I did undergrad at Michigan State, back to Michigan State for another 7 years of additional orthopedic training. Came to the Dakotas because of my love for the outdoors and to hunt, and went to the NME in Fargo. That's North Dakota State for you non-Bison fans. Spent 11 years there and then here to Sioux Falls and started practice here in Sioux Falls in 2004.
So you've been here now 12 years?
12 years this August, yes.
So, and what kind of orthopedics would you say you do? Mostly one particular type?
The first part of my career was certainly very dictated to sports. 40 high schools, 3 colleges, including North Dakota State. I probably did less of the things I do now as I've aged. I tell people my patients have aged along with me. Instead of taking care of 18 to 24-year-olds, I now probably take care of more 55 or 60-year-olds, closer to my own age. Both those athletes have worn out, and just my patient population has changed as I've changed from a sports-dictated type program to more of a general orthopedics with a bigger emphasis on arthroplasty, total joints, hip, shoulder, and knee is the primary focus of my practice for total joints.
Okay. I just got a message that the phones are working, so give us a call if you have a question. We'd love your questions, or call in your answer to the quiz question. So if you, so North Dakota, you moved down here because it's a lot warmer. Is that?
It is a fair warmer. I saw some very brutal times. There's a line around Summit that the warm weather comes south and the cold weather comes north. But I've been to Sioux Falls many times with NDSU sports programs, either to Omaha or USD or the playoffs down here, so it was easy to transition. Some of my fellow physicians had come here before me, and I just followed them down here.
So orthopedics is an interesting field. What drove you to go into orthopedics?
Played sports my whole life, from hockey on to a bike racing career, and then wanted to stay in the sports business. It's a musculoskeletal type program, obviously, and I was involved in musculoskeletal stuff. I saw it one time about doing obstetrics. Realized all babies come at 2 a.m. I had no interest in that after a while. Although my wife was an OB nurse, I didn't stay in the OB side of things.
So that's interesting, though, that you were an athlete.
Yes.
Did you play high school football?
I played hockey. Weighed a lot more than I do now, and
really
got a back surgery to show for it.
How many pounds did you weigh at your heaviest?
A little less than 180.
So you're down by quite a few pounds?
Well, my bike racing career, the least I weighed was 147, and I did the best racing, and now I'm about 160.
So you're halfway in between?
Yeah, halfway between.
I think that's healthy weight, Jeff.
Maybe you're right.
So the history of orthopedic surgery, I mean, you do general surgery now, in other words. I mean, you do hips and knees and shoulders and all of it.
When I'm on call, it can be anything from the broken femur to a broken ankle to shoulder to hand. My practice does not do necks and backs, which is certainly part of orthopedics. Orthopedics really started in the 1950s. It came out of the general surgery. Like all the surgical specialists started with general surgery, and it evolved from there as the tools got better, orthopedics. And there's still some general surgeons in the country that do some basic orthopedics, hip pinnings and some smaller things, but their practices evolved very specialized. And even in orthopedics, there's now subspecialists in everything. You could be just a hand surgeon, a shoulder surgeon, elbow, guys that just do total joints, guys that just do sports, just foot and ankle. So it's become much more specialized as practice has evolved.
And your group has foot and ankle specialty people where they've even developed artificial ankles.
One of my senior partners who's retired, his son is with us and developed the first toe ankle in the U.S. to be patented, and now there's many variations of other companies have developed that same technology.
So that's interesting. So artificial joints, I can remember hearing that, well, hips are pretty good, 95% success, knees are about 80, and shoulders are about 50%. Now, success meaning people are happy, they're functional, they didn't have a problem with the surgery, and they recovered well. What's the numbers now?
It's better. Shoulders aren't probably as good because the technology behind getting the shoulder to be fixed isn't as good, but we've gotten way better on shoulders. Their durability, and particularly with the reverse shoulder, which is meant for people out of rotator cuff that arthritis. The knee technology is probably 95 or 97%, with the complications being clot or infection getting us in the most trouble. Hips have no doubt done better. We made some missteps, particularly in the technology. Better metal, better plastic, ceramic. There's been missteps in what we've done, and we found some big errors. We put carbon in things we shouldn't have. But we're better now, and they are lasting longer. The problem is we're putting them in younger people, which means the durability is going to be an issue.
So that's the question. You put in an artificial hip. So I'm a 55, 60-year-old, let's say. I'm 67, not 60. But so you're a 60-year-old, and your hip's giving you trouble. When do you replace it, and is there a problem that that artificial hip is going to wear out?
The replacement comes when we lost what we call ADLs, when you almost need a walker. You can't walk around your house. You can't do normal household chores or outside chores or grocery shop or what I would call just routine things that preserve your health. If you can't do that, your hip is becoming a detriment, whether it's a hip or knee. Determine when it's your hip is a lot of different factors. Certainly more groin pain or pain in the inner leg. A lot of confusion with low back pain patients of what's their hip, and it's our biggest confusion in the office that my leg hurts. Hip and back are the combination. And if you look at all hips we do or all knees, 70% have a bad back in combination. It's the sort out process to determine. The hips are just like a knee. We don't have ceramic in knees. We do put ceramic in the newer hips, and they're pretty durable.
The ceramic is a
ceramic
better
is
deal?
probably going to be the way to go, younger or older. A lot of discussion. Insurances don't like the ceramic. They're a little more pricey, but if I had one, I'd want it because I think their durability and the plastic wear is less. Knees, probably, they're a little more aware than a hip. A hip is not meant to run. You see people running with a hip. I do it. My patients do it. My medical patients do it, and they drive me crazy. It will wear faster. Plastic fails by cyclic load. You pound on a piece of plastic with a ball peen hammer every day, it's going to wear faster than the guy who walks and does the right thing. It's not meant for running or jumping. The advertisements on TV are a bit of a lie. Their advertisements are done in a lab under non-biological conditions, and there is wear, and they need to be watched. You can't put one in and come in 20 years and say, okay, what do you think? They do have some parameters to be watched, and there's some risk along the way.
You can replace a hip if it's failed.
Yeah, we hope we get them early. That's why you watch them. If you put a hip in, you want x-rays every several years to watch the wear. And as it gets farther in, 10 or 15 years, to watch surveillance closer. You sometimes can just change the plastic. Changing the metal gets to be bigger and a lot bigger surgery, and the results aren't as good the second or third or fourth or fifth times.
Knees, they're better, that you can replace the plastic.
And the plastic can be replaced if you catch it early enough. The funny thing about the plastic, it makes the body has a macrophage, something in the body that wants to eat up the plastic. It also tends to eat up the bone adjacent to the metal. So yes, you can change the plastic if it's caught right, but when the knee starts to get loose, you'll need to change the metal too.
Okay. All right, well, we are back. We have something coming at this point. We all deal with some day-to-day pain, but when that pain and lack of ability to move freely stops you from doing the things we love to do, then it's time to take the next step.
With the hip replacement, I was getting to the point where I couldn't take walks. I was fearful of traveling. My husband and I had led numerous trips to Ireland, and I like to lead those trips, but I did a lot of walking. I would walk double what anyone else on the trip would, because I'd take them to a site, then go back a quarter mile, make sure everybody was okay, then go back to the site. So I walked a lot during that, and I loved it. But before I had the hip replacement, I realized I'm not going to be able to do those tours anymore. I'm not comfortable walking that far. So once I had the hip done, boy, with it, again, it wasn't fast, but within a year then, I started feeling 100% again. 2 years ago, my daughter, my granddaughter, and I took a walk in Germany that was called St. Patrick's Walk, and it was 22 miles cross country. And it was just pure pleasure. I did use walking sticks, but I could have never done that if I hadn't had my hip replaced. Well, after you come home, there is an amount of pain. You realize it's pretty traumatic to go in and put in a new ball and socket that aren't part of your body. So at least the first week, you feel like they replaced your leg with a log, because you have to lift that log. It doesn't feel like it's any part of you anymore. It is real. I think your leg is numb, it's dead, I don't know exactly, but it does not feel good. That takes almost 2 weeks before it feels like you could actually start using it. You're very cautious. I was very cautious with it, and worried, because they didn't want you to do too much exercise with the hip for fear that it would pop out of place. And I found out at that time that if you have a hip replacement, it's quite a bit different than knee, because knee, they want you to move right away. With a hip, it takes almost a year for whatever has to grow around that to grow around to hold the hip in place. I don't know enough about medicine to know exactly what's growing around there, but muscles and tissues. And I think more muscle was cut, and that might have been one of the reasons for my discomfort. And it was just a much slower recovery than I had anticipated. But yet, looking back, I would tell anyone to do it. It just makes a world of difference. If you're reluctant to get a hip replacement, it's your choice, but you have to realize that you will not have the mobility you had a year ago. And if you don't care, if you're just going to sit around the rest of your life, you'll be fine. Don't have it. But if you really want to continue a lifestyle, to enjoy the life you're living, to me, being sedentary is just not the way to live. Eventually, if I'm going to have both done, I will not dread having the hip as you would think I might, because I was not happy with the slow recovery. But everything I read and hear about now is the hips have improved so much. And now they're doing surgery in the front. I don't know what they call that, but the surgery is different, and it's cutting a lot less muscle. So I think if I have to have my other hip done, I'll just relax, go through it, and just know I don't want to be sedentary. I want to remain mobile as long as I can, and if it means having another replacement, I will have it, just so I can keep moving.
We can answer your questions now. The phones are working. We answer your medical questions about hip concerns as they are called in or sent to us via Facebook or email. Please call us your questions. We'd love to take some questions now at 1-888-376-6225. 1-888-376-6225, or send us an email to the address that's on the screen. And while you're at it, answer the quiz question. So what did you think about what Joan said?
Oh, probably somewhat true, but I think the recovery's gotten faster. Through our smaller incisions, less muscle, I think the patients are getting better quicker. I've seen that when I first started, you're in the hospital a week. Then I went to 4 or 5 days. Now a lot of my hip patients are in the right age and healthy patient out in a day or two, or even some the same day, believe it or not, because of the surgical procedure. The tools are better, and the injections we have for pain relief, trying to avoid the narcotic haze you get by taking a PCA pump or a pain control pump. We've stopped that. We've heard that's hurt our recovery, not helped it. But not everybody can go home in a couple days. It's just not true.
Some people have a higher brain pain or a lower pain threshold, and that's all there is to it. I mean, it's individual difference.
Very true, very true.
So she spoke about the anterior approach versus the posterior approach. Could you explain that to me?
An anterior approach to the hip, and I'll illustrate it here. An anterior approach is a muscle-sparing approach done in the front of the hip. It doesn't get near one of the nerves of the hip and does have a little faster recovery than the posterior approach, but it has about the same recovery at 3 months. A posterior approach has a little higher risk of dislocation, between 1% and 3%. It's been standard for many years, but at the same time, it's had some complications with muscle pull-off. So
is that the one? Yeah.
if you look at a hip replacement, we have to do the same surgery. We'll have to make a cut right through there, no matter how you approach it. An anterior approach will leave an incision up in this front of the hip, where a posterior approach will have an incision across the back of the hip, much like that. It involves taking the muscle off the back of the hip, where the anterior approach allows us to split the muscle, still dividing the hip capsule to gain entrance to the hip to make that cut. In a hip replacement, this bone has to go away, so that cut eliminates that head and neck area. We're then able to work on the cup, that's the glenoid or the acetabular portion. You can see from the drawing on the other side, this hip has been replaced. That's the cup. This hip has screws, which we often use, maybe more in poor bone than in hard bone. A stem is then inserted down, and where that neck cut was made, you try to recreate the hip geometry. Try to find a center of angle or center where it was in the past, get equal leg length, which is one of our challenges in hips.
Right. So if let's say that this is the plastic cup.
There's a metal cup with a plastic liner right inside, yes.
Okay. And then this is the ball, and this is the artificial part that's put in, and so you replace both of them.
Right. The part you see with the screws is metal, but inside there, that's the plastic. That's your new cartilage. That's the part that's several millimeters thick, and that's the part that wears.
Oh. So, but sometimes do they put in just if the acetabulum is all right, can they just put in an artificial hip and then put it into the artificial ball and leave the old socket?
Mainly for yourself for hip fractures. So a hip fracture in somebody who has a good hip, a lot of argument about this, who has a normal hip, you may just leave that because it allows you to have the extra time for wear. So if you wear it out later, you can come back and put a socket in. But almost all the total hips you get for an arthritic process, it's on both sides of the joint. You have to replace both sides to be effective.
Okay. Now you've made a point that this can sometimes wear out. This cartilage, this plastic can wear out. Can you leave that metal ball and go in and just replace the plastic?
It can be done at several years, and typically those are 10 or 15 years. What you have to be careful of is you need those serial x-rays. You need to have x-rays every so many years by your physician or someone to watch the plastic. You actually can see the ball change position. As it rides up, the plastic is wearing. And on your drawing, on the cup side, you'll start to see cysts or dark spots in the bone seen by your orthopedic surgeon. That means that plastic is migrating through the cup, at which point you need a change before it gets to be a big problem.
So cysts in the bone is up in here.
Right. That follow the screw tracks, and they follow up in the bone, and they're pushed up there by the plastic out of the cup.
Okay. So let's talk about hip fractures. This is a typical hip fracture. Could you explain it?
And the hip fracture is typically in two areas. There's those that break and fall, and there's those that fall and break. This is one that typically you fall and break. This is called an intertrochanteric fracture. It's a term we use for a fracture that doesn't involve the ball. It involves the anatomical area called the trochanteric region that goes through here. So this type of fracture cannot be fixed primarily with a simple hip replacement. It typically needs something to restore the hip anatomy. There's a picture following that shows a rod or a plate that fixes this hip because you're able to keep your hip in this picture.
Let's see, I think we have it.
That's a picture there. So on this procedure, you have small incisions to put a rod down through the bone.
Draw hard.
A rod in the bone from a small incision at the top, that goes through the middle of the bone. A screw will then grow through another incision up into the hip. That restores that fracture area, allowing that to heal in about 3 months on average. But it should allow you to walk on it right away.
So if you look at the ball and I don't know if this is a fair drawing, but then so show me where the different kinds of fractures occur.
So unfortunately, more common in ladies. And maybe men with osteoporosis as well. They'll get a stress fracture from poor bone quality or osteoporosis or a fall, and that fracture is commonly along here.
Okay.
And that's a neck fracture. You can put screws in it, but as we get older, the bone quality is poor, in which case you need a partial hip replacement. Now, there's examples of those folks who have a moderately arthritic hip who weren't having symptoms, who I would put a total hip in when they fracture it, because I don't want to come back too soon, save the healthcare costs money. Intertrochanteric fracture, and varieties in here.
Which we just talked about.
That's this picture adjacent to it. That requires fixation. This doesn't, you can't put a hip in there because you're below where the bone quality is. So you have to do something to span across that, either a rod inside or a plate with screw across to hold that and let that heal. And that, so a partial hip here has its own side effects, but they walk faster and easier. The hip fracture is a little harder because that muscle's involved and it is a slower recovery. They walk on it, but gingerly for several weeks, if not a month or two.
So I've heard that when this fracture occurs, this one right in the neck, oftentimes the ball loses its blood flow. So you can put that rod in there, but then, you know, as months go by, this thing just deteriorates.
20% risk if you put the screws in, and younger people we try to. There is some ways to get around it, but if you put the screws, I don't care how good or how young you are, that blood supply comes in at certain places. If your blood supply comes in here, you might get lucky. If your blood supply comes in here, you've broken it, that ball will die, and you will get, on that term before, avascular necrosis or a dead hip. Happened to Bo Jackson, those remember old sports injuries.
Oh, yeah.
He dislocated his hip and got AVN, either from steroids,
Avascular necrosis, loss of blood flow.
supply, or he got it from the dislocation, which interrupted the blood supply.
Well, and he was getting steroids. I mean, they give steroids right and left to those athletes.
Anabolic steroids haven't been the problem. The steroids that get you in trouble is the kind that we take for multiple medical conditions. Almost every patient that gets a kidney transplant gets some form of avascular necrosis.
I had a patient who had severe ulcerative colitis, and so I called my gastroenterologist friend at Emory. This was early in my practice, and he said, up the steroids, up the steroids, up the steroids. So I'm treating his colon, and he was getting better, and his hip rotted away. And so he ended up with having replacement hip.
And it's a poor procedure for us because avascular necrosis doesn't leave us good bone to put the hip in. So the purchase of the metal in the bone is poor in that group. Because they haven't walked on a really hard, angry hip, the bone hasn't hardened because of the stress. That's a harder hip because that bone is softer, both from your steroids and from not having a bad hip to start.
So that's a tough scenario.
That's the hardest, much like rheumatoid patients.
Now, you talked about, we're talking hip replacement right now. The first hip replacement was?
Early in the 1800s, it was made out of ivory.
And did it work?
Not very good. I've seen pictures. It actually is done in England. England's had a fair amount of hip information long term.
Uh-huh.
And then here in the U.S., came in the 1940s. It was a partial hip. Somebody just put the hip stem in and it would rotate around inside the bone, but that's all we had. Then we started to develop cement. We took what's called PMMA from our dental colleagues and used that cement in these hips. And if you look at this picture here, you can see cement in this hip down at the bottom.
Oh.
And that allowed the hip to be cemented in the bone when you had
Right.
poor bone quality. We then got something else, we got cement disease. So the hip got loose in the cement, made a hard problem for us. Now, majority of our hips are press fit or pounded in.
Without cement.
Good quality bone. It has to be better quality bone and it actually has better longevity.
So they're sometimes you use cement, but not mostly. And that's what you were alluding to. We made some mistakes along the way.
Yeah, we found and cement has its own set of problems. It's hot, it cooks the bone. So it's not, in a very, very thin bone, cement has no place to hold itself. So there's some challenges. Not every hip can be fit for every patient. Some need cement, some don't.
So let's talk about the issue of hip fractures more and prevention of hip fractures. I know that in my population, the geriatric population with whom I care for, we see a fair amount of falls. Any comments about fall prevention that you'd like to make?
Home is the biggest place. And of course, everybody likes to have their throw rugs on their kitchen floor. Very bad deal. All that kind of thing has to go. Even the bathroom, I see more fractures in the bathroom with throw rugs on the bathroom floor, a tall bathtub to get into without some kind of a protection. We see fractures every week in our practice in Sioux Falls and from here in Brookings as well, who they tripped over the bathroom or tripped over a rug, and I always ask the family the question. They say, no, it's not. When we get home, they will be taken out. And balance issues. As we get older, we get some balance issues just by default. So balance exercises or prevention of balance exercises and hip strengthening is important, and even shoe wear is important. People can't be afraid to use a cane or a walker to protect themselves from falling.
You know, so one of the things that I'm doing right now is I have groups of 8 to 12 that I'm trying to encourage, and they're 70 to 95 years of age. And we're working on a dietary education, but we're also talking strengthening and walking. And as we get people to walk outside, I really love the idea of a walking stick. And you can buy a dowel at the lumber yard and with a handle and a rubber thing. But it really isn't that it needs to be strong to help you. It's there to tell you where you are in space. I mean, if people get up in the night to try to find their way to the bathroom, just touching the wall, touching the cabinet, touching the table tells you where you're at. All you need is a yardstick to tap on the ground to tell you where you are. It's a third kind of a sense of another leg.
I would always tell patients, if you have a bad right hip, put your walking stick in your left hand or put it the opposite side. It seems counterintuitive, but you carry heavier weight on the bad side, but you put a stick or a protection on the opposite side.
Yeah, isn't that amazing? That's an
Your
interesting.
body wants to lean away from the pain, so you want to help. So you have stairs in your house, you need to put a railing on both sides for up or down. So we've seen a lot of people that probably fall that shouldn't with some household things. A therapist can help you for sure.
Occupational therapy, that's their job, fall risk.
And then trying to get people to, as you get neuropathy, which is a common thing in aging, as well as the diabetics, the risk gets higher. Shoe wear, pretty important.
What do you know about shoe wear? I've heard that the best shoe wear is cheap running shoes, just athletic shoes, that kind of thing, instead of bare feet, certainly instead of slippery socks.
Yeah, stockings we know are a problem. We see more people step on a hardwood floor and the rug goes out and they go down. So yeah, tennis shoes or shoes that fit your foot are better. People ask me about the clogs or those rubber shoes. I hate them, but I'd rather have that than socks. Yeah. The old molded piece of plastic that seem to last not long, but even those are sufficient. Especially in the diabetic patients, it's even harder because their proprioception or balance on the floor is quite poor. So their fall risk is high.
I have an 80-plus-year-old English professor who tells me that she loves the kind of shoes that doesn't have a back, right? So you have to grip them with your toes, and because it does that, it exercises her, she says, and she thinks that that's made a difference. The experts say no, running shoes, or just the athletic shoes.
Heel in the back is kind of important. You don't want to have an open heel shoe. And even those people you talk about, we know people in their 80s can still do strengthening exercises. You may not build muscle, but you can still strengthen 80 and 90-year-olds. There are studies that shows that you can increase their cardiovascular ability by walking exercise, which diminishes their chance of a fall.
There's one theory about stretching, though, too, and that is that a muscle that cannot elongate can't constrict, so there's no movement, there's no function. So that if you can stretch your muscles, the stretching is a very important thing. And the balance that you talked about, that was another important thing.
And balance is hard because as we get older, we tend to lose balance, or proprioception, we call it. It's a big issue. You look at people and you do balance tests, and it seems to equate with the patient's general health. You look at somebody who has poor balance, and their health seems to go with it. The question is how to do it. Getting in one of these classes you recommend. Water exercises seems because the water gives you balance. You don't become a bit of a couch person. You lose that, and those things lead to me.
So those guys who walk at the circus across distances on a tightrope, they get that ability because they practice it. I think if we could get older people to practice heel to toe, practice balancing, they would get better.
Yeah, we tell them that after a hip. A person who limps badly before a hip will have a little harder time beating the limp after. Somebody who comes in without much of a limp does it better because they have to unteach their brain a bit to get over that sensation. I'm going to wait before my leg catches up.
Oh yeah, and we heard that story from Joan. It took her a while. The ability to control your balance is essential. Without good balance, your movement is impaired and a fall could result.
Balance is important at every age. Whether you are 20, 30-somethings and you're having a baby, your center of gravity, your center of balance changes with a pregnancy, so it's important for you to be conscientious of the balance at that point. But also as we get older and we age, we know that we get a little bit weaker in our hips and our core, and sometimes with weakness we get increased risk of falls, especially over the age of 65. And balance is always important. We need balance to help us walk on level ground as well as walking in stairs, and it helps us to continue to be independent in our homes. If you feel like you're falling or you're starting to lose your balance, make sure you mention that to your doctor, because one of the signs of falling is a previous fall. And a fall does not actually mean you hit the ground. A fall means losing your balance and having to catch yourself on the wall or lean up against an object to catch yourself. So just make sure that everyone's aware of the definition of a fall. So it's always important to make sure you have a sturdy surface to hold on to. So whether it's the back of a chair, can I have you come around this way, Carly? So you can hold on to the back of a chair, or you can hold on to your kitchen sink or a counter at home, tabletop, something like that. That's about little under waist height, so it's comfortable to rest your hands on there. And a couple of exercises we're gonna do. Main thing we're gonna do is we're gonna work the leg muscles. So your glute muscles as well as your hip muscles. And I really want you just to start by marching. So let's have you hold on right here, Carly. And go ahead and just march. This is very important because as you're walking, you have to use one leg and then the other. So you're building up strength as you stand on one leg, but also as you move the other leg, because we need hip strength and glute strength as you're standing here, and as you lift one leg up as you do when you're walking to bring it forward, you have to have strong hip muscles on the side that you're standing on. If you don't have strong hip muscles here, then you don't have the stability in your hips and makes you more off balance. Okay, another exercise you can do is you're gonna just kick your leg gently out to the side, just a little ways, calling this side kicks or hip abduction. And make sure you do both legs. Another one is hip extension or kickbacks, and you're gonna do this gently, and just back like this. The important thing is to make sure you stand up nice and tall. Don't want anyone leaning over their chair. And generally we tell patients to do, 10 to 20 repetitions of each of these exercises. Another thing you can do is just standing with your feet close together and trying not to hold on to anything and see how your balance is. Do this with your eyes open or your eyes closed. If your eyes are closed, it's a little bit more difficult. You can also stand one foot in front of the other. Again, when you're doing this, I'd have a chair or something to hold on to, okay? And again, make sure you do both sides. And if you're gonna work on these balance activities, I would have you do it for 20 to 30 seconds at a time, 3 to 5 repetitions at a time. It's important to do these exercises every day, because if you only do them once in a while, you're not gonna get the benefit. But if you do them every day or even twice a day, you're gonna get a lot more benefit from these exercises and help improve your balance, and if nothing else, maintain the balance you have so you don't go backwards anymore and make it harder for you to live independently.
This is your show, and your questions are key to our show discussion. Call in your questions about our marvelous hips to 1-888-376-6225 or send an email to ask@prairiedoc.org. So we have a 20-year-old who has a question about her hips hurt when she runs. Have any feedback on that?
Well, a runner's a little different than some. When both hurt, unfortunately, sometimes it's mechanical. Your low back can cause hip pain, but a lot of female runners, more than males, will have IT band problems.
Okay, IT band. Let's talk about that. Do you have a drawing? Let's see if we go to a blank.
Just pull up a hip picture.
Okay, hip picture.
That one. So the iliotibial band or IT band is a common thing. We call it IT band syndrome because we don't have a good answer for it. It's a muscle that comes off the pelvis. Unfortunately, it goes across 2 joints, goes across your hip and all the way down past the knee. It allows the knee both to extend and flex. So runners, and particularly in females, tend to have more problems with their IT band, and typically it can bother at the knee or at the hip in this area. And it's also called snapping hip syndrome. There's internal hip snapping and external, and it can bother right at that spot. It's very frustrating. Some has to do with better abdominal strengthening or core strengthening, sometimes with shoe wear, and sometimes with overall leg alignment. Very frustrating for many college and other runners. Look at your run. If you run on it off camber on a road with a tilt on it, you always want to be careful you don't run always with the one leg down. If both bother, it's not the case.
If you're running on the right side all the time, run on the left side, but be careful, don't get run over. That
Yes.
type of thing.
The downhill leg is the one that gets the stress that reaches farther out. If you're running on a treadmill, don't run with it 1 degree or a ½ degree at minimum down. Don't run with a treadmill flat. In effect, you're running downhill. You want it up a degree or 2. IT band problems are common, a little bit associated with low back disease, but in younger running females, often due with a number of factors: hip mechanics, core strengthening, and knee alignment, and even foot alignment. Even a bad arch can lead to some IT band, a very frustrating part of sports medicine, both at the knee and the hip.
Let me throw this at you. For the longest time when I was running in Atlanta back in the 70s, I'd have knee trouble and back and hip and ankle trouble when I'm doing a lot of downhill running. Going up was okay. When you come down, it was worse. And I came to the conclusion, correct me if I'm wrong, and this is my question, that what happened is if you have enough time to run, when running downhill, you have enough time for your leg to straighten out. You end up on a straight knee that coming bang, 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 instead of a lower knee that has a cushion when it comes to it. So if I got lower to the ground, my problem went away.
Yeah, it's like running uphill. Running downhill, you have to overstride because you're reaching, running downhill is always harder. You have to almost lean back and bend your knee. It causes you to overstride and leads to a lot of mechanical problems. You tend to overplantar or forcefully force for your foot. Your knee tends to hyperextend, and your muscle of your knee muscle have to correct it to pull it all back, and that leads to low back issues because your pelvis is overcompensating on, if it's one downhill side, they're off camber road, or running downhill. So you don't see many college athletes running downhill for practice. First, it's not hard enough for them, but they're running uphill for that reason as well.
Right. We like them to bend their knees, come down on a bent knee, not a straight knee, not a hyperexpand.
True for college, any athlete, of people that land from any kind of running or jumping on a straight knee, if you hyperextend it, your knee won't last long because you're going to tear your ACL. A little bit of hyperextension in knee will do nothing but damage it.
All right. So let's talk about the issue about prevention exercises. We alluded to the idea of strengthening the hip muscles. What particular exercise can my 70-plus-year-olds do to strengthen their hip muscles, keeping them from hip fracture so easily?
Non-contact or non-aggressive stuff for sure. You know, any stretching is good. Certainly people see Tai Chi, and there's been multiple articles about Tai Chi or balance exercises. Yoga is a stretching exercise. Of course, when you have a hip, you got to be careful how far you stretch it. You can't put it in places it can't go. Any kind of walking on a treadmill will help you, and it's relatively safe because you can always hang on to the hand.
Right.
I'm a cyclist, so I like bike, but you got to be careful about the bike position. You need to have somebody set it up so you can do it. And the balance portion is something you can do in a pool. The aquatic programs we see is certainly an easy thing because it gives you a sense of balance in the pool. Every place has a pool and you can't do it, but even at your house, even doing steps, where you're doing a couple steps, you can do repetition, can be done easily. Something you can do every day for 15 or 20 minutes is not a very big exercise program to stimulate your muscles to do that. Even when you're watching the morning news or whatever you may do, there's no excuse you can't do it sometime in a day.
What about deep knee bends, or sitting in a chair, standing, sitting, standing, sitting, standing?
Yes, until your knees hurt. The deeper you squat at your knees, the more pressure you put on already damaged knees. So if you're talking about 70-year-olds who are trying to protect their hip, you don't want to aggravate their knee. So anything that gives you body weight exercise, you know, if you go to a gym and you go on vacation, you don't have a gym, you can do body weight things and learn some of those things. And the therapist could be good to teach you some of those, or even the trainers or other people in town are good at hopefully home instruction. Say, here, learn. Because us physicians, we're more about taking care of once you get hurt. We're not good at the beforehand, because you see me after it hurts, not before.
Right.
And can you get to somebody to teach you? And these classes are very beneficial for that. Even in Sioux Falls, it's the Active Generations, and other places here in Brookings as well.
Right. So you have mentioned to me before this show about the cost of hip fractures and the problems, the societal cost. How much does a hip fracture end up costing if you look at the total story?
It is phenomenal. There was one study in 1987 that told the hip fractures in 1997, just that year, and their life expectancy would expect to cost the American taxpayer $20 billion for that 1 year hip fracture, to care for that patient the rest of their life. That includes all kinds of care, not just the hip. But an average hip fracture in the U.S. is about $81,000 to get there, the nursing home, the care afterwards. It's a lot of money. And the mortality and morbidity is really high.
Well, I've heard 20% will be dead within the year.
We tell people in the textbook, as I tell people, the more things you come with wrong, the worse you're going to do. 20% morbidity often in the first 90 days on the people that bring problems with them. And the mortality is not far behind as far as if you come with medical problems. A hip fracture, not hip replacement electively, is very, very bad because it puts way more pressure on systems that can't afford it.
Right. 81-year-old woman asked what would cause an infection in the hip joint following a hip replacement, the infection rate. That's a great question.
We don't like it. The textbook is somewhere 1 or 2%. If you get it right away, it's from the surgery. It's usually within the first 2 weeks, not in the first 3 days. You don't typically get an infection in the first 3 days. It's usually other reasons. It's almost always staph or strep. It can come out of any place in your body. We know the mouth is a common place to get infections. Later infections, several years down the road, come from some other infection someplace else that settles in the hip. Okay. So it usually comes, we call it hematogenous, from the bloodstream.
From the bloodstream.
Initially, we can get it from the hip, from the blood around the hip. We use blood thinners. They make for more swelling. You can get it right away from just in the OR, in the hospital, that can get a hip infection. Very bad deal. It has to be reoperated. You can't just give antibiotics and get away with it. It needs to have another surgery to clean it out to get ahead of it.
You need to take out the the artificial parts?
Well, sometimes if you've done it early, this is always a question. If you can get the infection the first 2 or 3 weeks, if you can diagnose it appropriately, you can take the plastic out and do a complete washout and put it back, and the failure rate's 25 to 50%. That's high. It means IV antibiotics for 6 weeks and maybe longer with oral antibiotics. If it's many long-time infection, it all's got to come out, and you got to have a spacer put in and go back and get another hip after several months, a very long and costly procedure and hard to get back from.
Tough. 67-year-old man from Martin has pain from shoulder to elbow every day. Pain from shoulder to elbow. What test would you best show what problem might be?
It's not his hip.
It's not his hip.
In that area, it's probably his bicep, or that's the only thing that really lives in that area,
Yeah.
or it comes out of your neck.
Could be a neck problem
Yeah,
too.
so
couldn't it?
cervical spine or neck problem, just like your low back controls your leg, your neck controls your arm. So if you're having pain at rest, and it's in between there, and the muscle has an issue, it's probably a neck problem. If it's when you use it, it can be a combination, but your family doc should be able to give you an idea.
Yeah. 80-year-old woman from Custer had bursitis in hip this summer. Symptoms resolved now, has had a return of symptoms in her hip to the point where she's no longer able to sleep on that hip at night. Should this be a cause for concern? So epitrochanteric bursitis, explain that. I'll draw a picture here.
That's kind of the drawing I had, like the IT band, we're at the same place.
Yes.
It is kind of the trash can term of the hip because it's rarely just trochanteric bursitis. Unfortunately, it's more common in ladies. They tend to have a little wider hip. We often associate it with low back disease, but those that can't lay on it or cross their leg can benefit by therapy, including stretching, and occasionally even injections into the bursa, which is just a blister between the IT band and the hip bone proper.
Right. Okay. 58-year-old man from Flandreau. First and foremost, the caller stated he'd be lost without this show, so he thanked us for. Thank you. His question is, I had hip surgery in August of '99. My hip is functioning perfect. How long does a hip replacement usually hold up? And what's the outlook for hip surgery in years to come? He's 58.
It means he had it when at 50 years of age or younger.
17 years ago.
Yeah, so
Yeah.
he has had an older generation hip and should be having serial observation of that by routine x-rays. And probably see an orthopedic surgeon or have him sent to an orthopedic surgeon and say, hey, how is this worn? And if you have other x-rays to compare to, very important, what is my progression of my wear? How fast has it worn, and what do I have to do? Can I do something before it gets too bad? It will wear out. He'll have to have new parts. He cannot pound on it to make it live longer. But at his age, he's on the end of that hip's lifespan.
All right. 72, and the newer hips last longer than those in '99.
Yeah, the designs are better. We did make some backward steps, but now I think they're longer. Now with ceramic and new polys are all ceramic hips, I think we should get longer.
Okay. 72-year-old woman from Sioux Falls, Dr. Kalo. I have arthritis in right hip, but not bad enough to do surgery. I've been doing water exercises. It seems to be helping. Is it possible it's actually helping, or am I just imagining things?
No, you're helping the hip become less stiff, which helps you get better motion that eliminates your hip pain. You can't help the hip arthritis. It's a progressive disease, but you able to help your core strengthening by also probably helping your hip muscle, which strengthening helps muscle arthritis because it helps you get around the joint, and you're probably stretching the hips. We know when hips get arthritic, they get stiff. If you're helping the mobility of the hip, you're able to walk better and not as having as much downtime when you try to get up and get the hip to go.
My sense is that many people can get by without the surgery. They might be quick to want it. What would be the major thing that you would say brings you to think a person should have surgery?
When they can't get out of the exam chair because they have to limp to get up or have a cane, it's not just because I had hip pain for a week or a month or even a year. It's, hey, I've lost the ability to take care of myself. It's starting to make me stop. Or more important for me as we get older is I think I'm going to fall. That is the worst thing you can have because by the time you fall, now you've made another problem. So if you feel unstable and it gives out, it's time to see a guy like me, either for hip or knee.
70-year-old woman from Mobridge is having neuropathic pain. Doctors wanting to do a spinal stimulator. She's described this as an implant to the spine, stop the pain from going to the brain. Is wondering what the doctor's thoughts are about that.
It's not where I live, but it's not a perfect science. Neuropathic pain is, where's it from? Is it out of your back? Is it out of the nerves? If it's out of your back, that's probably the right thing. If it's from diabetic neuropathy, it hasn't had any effect. The medications for it help the pain, but not the numbness.
No.
So it's a tough deal. That is the hardest thing we deal with.
It is a really expensive option, and it's early, so I'm a little conservative on that one. 65-year-old woman from Lenox, I had one hip replaced a year ago. I was told I have hip dysplasia. Can this be fixed after my hip replacement?
Well, dysplasia means your hip and socket didn't form right when you were right out of birth, using the first 3 years.
Right.
So those people almost always get hip disease in their 4th or 5th decade. It's one of the most common causes of hip arthritis early if it's not traumatic. It requires a little bit of different hip surgery. It requires the socket is not made right, and the ball is easy to fix, but the socket oftentimes needs a change in the socket orientation and a little higher risk of dislocation after the surgery. But it can be done with the technology we have.
Okay, so there's hope for this person, and it can be fixed.
Yes.
67-year-old man from Millbank, caller's been wheelchair bound for 45 years, is now experiencing shoulder issues, little cartilage remaining in his shoulder because he's in the wheelchair.
Right.
Is there anything that can be done to improve shoulder mobility, and what's the success rate? Oofta.
Well, the problem is if he needs his arm for a wheelchair, he'd
Yeah.
have to give up one for a shoulder replacement. And we see this occasionally. You see somebody's got one arm and the other arm doesn't work, and the one they've worn out, what do? They'll have to put up with several months of convalescence. Injections don't seem to help shoulder arthritis like they do knees, and maybe not as much hips. So he'll have to either deal with the arthritis, use something reasonable for pain, we need some medication, or consider replacement of one and get that good enough, he would consider the other. But it will be a challenge to him because he'll need more help. He probably will need to go to a care center initially afterwards to be independent.
To recover. 87-year-old woman with Sioux Falls cerebral palsy had a hip replacement at 16. How long can that be expected to last?
How old is she now? 82?
She's
Wow.
87.
If it's lasted that long, I'm amazed.
And we're happy.
Yeah, so it should have worn out by now. How it hasn't, I don't know. I would take the surgeon who did that and tip my hat because that would be something we haven't seen. It's a problem with cerebral palsy if it's the affected side because how do we control the muscle afterwards?
Yeah.
Typically it doesn't involve the hip muscles as much as it involves other parts of the extremity.
They're in spasm most of the time.
Right, and it's a hard thing because if they're kind of dislocate, it's a disaster and they end up with a hip procedure that doesn't work well. So I would be thankful and make sure she's having some follow-up x-rays to look at it.
More physical therapy, less surgery. 82-year-old woman from Wessington Springs, which is harder to perform, hip or knee surgery? Great question.
Yeah, to me, about a 35 or 40-minute routine knee surgery and a little less than an hour hip. The hip is a bigger surgery, but a faster recovery. Longer lever arm, the knee's a easier surgery, harder recovery. More bleeding from the hip as well.
Okay. 76-year-old woman from Brookings, what exercises can I do post-hip surgery to get me walking sooner?
It may be pre-hip surgery. If you want to walk better after, you may be better exercise before.
Before, there is a key. Remember that. Exercise before the surgery.
Try to get as good as you can before because you're going to go down.
And just walking?
Yeah, walking is great. And if you can't bike or elliptical or new step, these things that we have out there that you can protect yourself from falling. So if your hip is bad, you can't walk outside well. Therapists certainly, but maybe you only get so many therapy visits in a year. You don't want to burn them before. But a hip replacement doesn't take much therapy. Gait training and a therapist for a few weeks is all you need. Then it's just keeping at it.
All right. Thank you, Jeff. And now for the winner of tonight's Prairie Doc quiz question. 1 in 5 people 65 years of age or older die within a year after their hip fracture. True or false? The answer is true. It was Lynette Hardy, thank you, Lynette, who answered the question correctly. We appreciate your call and participating, and a book will be in the mail to you soon. So any comments about that particular?
Very, very true, very true. So we see people that are healthy, community ambulators, we often tell them they're going to drop back one level for a while, maybe assisted living to get home. Those that start in a skilled nursing facility or nursing home really struggle. They are never going to get out of there, and oftentimes they have the high morbidity rates. Those are home independent and fall from a traumatic event, going to get there, but they're going to work at it. So the older you are and the less you are a walker ahead of time, the less likely you will be independent when you're done, and often lose that independence. Very frustrating.
So we want people to keep their independence. Keep walking so that you don't end up losing that independence.
A broken hip, we know, is very costly and very dangerous for a patient's health.
We'll be right back after this.
Good day, citizens. It is with regret that I inform you that the end is near for me. I'm old, I'm tired, I'm weak. But don't go thinking that you've won the war against the flu. Before I go to that big petri dish in the sky, I will find a suitable replacement. Be warned.
As a kid in country school, she ran faster than others, fell a lot, always picked herself up, and knee scabs were part of her story. Now, in her 80s, she's been falling again, especially after medications for leaky bladder, blood pressure, and pain were started. Last night, she fell in the bathroom, couldn't get up, and remained there until the neighbor checked on her this afternoon. The hip was broken, and after repair and recovery time in the hospital, she moved to the nursing home. More than 1/3 of Americans older than 65 experience at least one fall every year, with nearly 2 million of these people ending up in the emergency room. Once in the ER, 60% have a fracture of some kind, and 9% have head trauma. Falls in the elderly can cause many problems, most commonly fractured backs, wrists, hips, and arms, as well as brain damage. The mean age of those visiting the ER from falls is 79. 76% are women, and more than 300,000 people with hip fractures need major surgery every year. These injuries cost our society billions of dollars every year, and not to mention the physical and emotional cost to the individual who has to endure the pain and disability from an accident. Falls are caused in elderly because of many reasons. Older people have slower reflexes, balance problems, reduced muscle strength, poorer vision, and are more often plagued by any generalized illness. Too often, elderly people are not exercising or active, resulting in a softening of the skeletal structure and a higher risk for fracture. This risk of stumbling and falling increases in the presence of loose rugs, cluttered floors, poor lighting, exposed electrical or telephone cords, and stairs with no handrails. But probably the most alterable risk factor is the medication list. More than 20% of people over 55 of age are taking more than 4 prescription medications, and it only goes up with age. The worst fall-inducing culprits include gabapentin-like medicines, benzo-type sleeping or anxiety pills, digoxin, narcotics, diuretics, and meds for urinary incontinence, high blood pressure, heart disease, and prostate problems. Well, meaning care providers sometimes add meds to every new complaint, and we can forget to take away the old ones. Falling risks multiply with too many drugs. It's imperative that any patient or family member push the doctor for less, not more meds. Pills can cause spills and broken hips. Well, a great big thank you to Jeff Kalo. His experience brought great insight to our topic tonight. The flu, it's here, folks. Here in South Dakota, we have a handful of cases already. Last year it was March when we were getting them. Now it's happening in October, November. Nationally, there are reports from almost every state. We're just getting to the time of year when the flu usually takes off. Don't delay. Get your flu vaccine now to reduce your chances of catching the flu bug this season. Dr. Kalo got his flu shot. I've got my flu shot. Do it. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people. Hello and welcome to On Call with the Prairie Doc After Hours. We had many great questions submitted beyond what we could answer during the broadcast portion of our show, so let's get started. Via email, ankle joints. Could you talk more about ankle joints, please, and how is the development of ankle replacement coming along?
Well, it's kind of gone backwards and forwards, probably. My partner's father started the first ones. It took him several years, and he said an airplane to fly back and forth to Indiana to get the design right. The problem has been it's a small joint. It's had plastic issues like we have other joints. It's gotten better. It's not meant for a high demand person. It's best for people who are a little lower demand or are willing to take lower demand. And it too has a higher revision rate than hips or knees.
Okay.
The other option is ankle fusion for younger people who are unwilling to follow those rules. Very successful, but it leads to further foot and ankle problems. But it's a good in between for many folks.
Okay. 77-year-old man from Orange City, Iowa, had a knee replaced 20 years ago and is wondering what the life expectancy is for that knee before he should think about getting it replaced.
Right about now.
20 years?
Yeah, he should. The 20-year-old knee, most of the ones I'm redoing now were put in the 90s, and that would put it in that group. He should at least have some x-rays to see how bad the plastic's worn. If his own surgeon's retired, certainly another orthopedic surgeon that comes there from CNOS out of that area would be able to look at those pictures and say, here's your wear, hopefully have an x-ray to compare to and tell him how much wear and how much time he's got left.
Okay. Comment, only 84-year-old woman from Mitchell. I have had 3 hip replacements done. I had no problems with recovery, could walk within a week.
Fantastic, about as good as you could ever hope.
84, doing great, 3 hip replacements. I know that you only have 2 hips, so probably had to redo
There
one.
was a redo. When a redo to do that well is pretty good because you're going back through scar, harder surgery, and expect a longer recovery, more difficult surgery too.
Okay. 66-year-old man from Alcester. I just had hip surgery. Does anyone go back in after surgery for a cortisol injection?
I would think cortisone in the hip, but the answer is you don't want to put steroids in total joints. We know it increases their. You don't want to put needles in, first of all. It's always risky for us. We do it to look for infection, but to put things in a hip after it's replaced,
You could introduce an
you
infection.
do not want to do that. You could inject the bursa. We talked about that earlier, the IT band, but not the hip proper. That would be no.
All right. 70-year-old man from Marion. If a man has been on 5 milligrams of prednisone for 5+ years, how would this affect his hip bones and joints in general?
Well, no, we know how much, but we know the steroids, prednisone, soften cartilage. It's a known fact. It inhibits prostaglandins, which cartilage needs for synthesis and fluid. It will weaken his bones, and if he's on, that's not a high dose, but that
not
dose.
that bad.
But he probably should think, even as a male, should have a bone density study to see what he's at. And he isn't a high risk for AVN like some of my patients that take high dose steroids for a prolonged time for different medical problems.
I like the idea of increasing walking so that it enhances the bone strength, and I would contend that an exercise program is heads and shoulders over the Fosamax or any of the bone.
We've seen many problems. I wish I could tell you as an orthopedic surgeon those drugs have been great. We've seen fractures from them. We see a lot of GI problems, and I tell my patients if you're going to take those drugs, which I think there may be a place, look in 4 or 5 years, stop them, get a holiday, and look at other options that are coming.
I think the better option is a regular exercise, weight bearing. One exercise is slight hopping, so that you can strengthen that bone.
Walking's about as good as, if we can get people to walk, you'll help me a ton.
Boy. 62-year-old man from Rapid City has had both hips replaced. It's difficult to get the legs the same length.
It depends on where you start. Certainly that's our challenge in surgery. The first guy gets the easy. The second one, you got to balance it. There's more factors than just the hip that don't, because your femurs may not be the same length from a kid or a broken leg. If they're equal to start, it means the surgeon might have added or subtracted to get the muscle tension right. If it's way off, you need a lift in your shoe. You build up the short side, obviously, and you can put a certain amount in the shoe and the rest is out. A redo surgery for that, complicated, but there's a few that just get so far you have to. It's not the first choice. A buildup of a shoe would be the first choice if it's not too severe.
Okay. So, I mean, in that, it just happens, doesn't it? I mean, what is the right length?
In surgery, we do have some ways to measure. The problem if you had a previous fracture, or you measure before you start, you do an x-ray, you try to judge and get in the park. The prostheses we have now are pretty easy, but say you can't get it in just right, do you hit it harder to break something, or do you leave it a little long, try to add a shorter ball? There's some pieces that you can adjust, but it is a bit of a Kentucky windage sometimes trying to get it, but we can get within a 1/4 inch.
Kentucky windage?
You look at it and you think you're the best you got, and you kind of give it a little eye and hope that that's right. But we do have some measuring things that we can do in surgery with x-rays to help us. And now computer surgery has helped us with that a bit as well.
All right. Man from, in other words, yeah, it's hard to get it just the right length.
Yeah.
Man from Sioux Falls, is there any way to strengthen the bones to prevent a break? We talked about that. My favorite is an exercise program.
Yeah, walking for sure. If you can't walk, I got nothing I'm going to do to help you. No drug is going to help you.
No.
If you don't have weight-bearing exercise, calcium and vitamin D, there's no bone that's going to get stronger.
And there's some new data. Have you heard this? Women who have vascular disease of some kind, history of some vascular disease, if you put them on calcium, it worsens the stroke
You
risk.
got to be careful about the calcium in all groups. Just like the glucosamines we see, primarily supplied to patients, there's some cholesterol patients that should consult their doctor before they take glucosamine over the counter.
Yeah. I would say vitamin D 2000, forget about the calcium supplement. Would you agree?
I would say in people, unless they have other risk factors, I look at some people who are early post-hormonal or have had gastric bypass or abdominal problems, they got to be careful because they don't pick up calcium out of their diet.
Okay. 78-year-old man from Sioux Falls just had a scope surgery in left knee a month ago. 2 tears of the meniscus came out of surgery extremely bruised, groin to heel. I was wrapped tight with ACE bandages. Is this usual to have so much bruising?
The bruising probably came from the tourniquet. When you do a knee scope, often we have a tourniquet and it's squeezed tight in the thigh, and I'm guessing the bruising wouldn't come from the knee. Typically with the scope, the blood would stay in the knee. I'm guessing the bruising came from the tourniquet because it squeezed on his thigh and it leaked the veins a little bit.
And he took his aspirin up and too close to the
Could have
time
been,
of the
but
surgery.
I would guess tourniquet more than knee on that case.
Via email, what causes bursitis? I sit at work all day. Can that cause bursitis? And if so, what can I do to relieve it?
Get up frequently and get about. Bursitis is basically a blister. Bursa is a normal fluid accumulation between tendon and bone or between tendons. It's a lubrication. You're supposed to have the bursa.
Yeah.
It gets pathologic when it gets thick and full of stuff from irregularity, and unfortunately sitting doesn't help it. Cross-leg sitting is worse for it. Stretching would help it, but not sitting all day would be a benefit. And probably if you sit all day and get bursitis in your hip, I would worry your back may have a bit of a problem as well.
So get moving and start gradual.
Yeah, you need exercise. Sitting all day we know has no good. Sitting is the worst exercise we can do.
Yeah, sitting.
Yes.
Yeah. Do any replacement hips have a 2-piece stem and ball so the ball could be replaced without having to reinsert the new stem?
Yeah, almost all the ones now, some have 3, that's been a problem for us because had too many pieces. Almost all the balls can be taken off. When you change the cup to put a new plastic in, you take the ball off, put a new ball on, and put a new liner in. So almost all the new ones that are currently available are 2-piece.
So replaceable. To 62-year-old woman from Aberdeen, I've inflamed bursa in my hips, and I developed one by my ischium. What are these?
The one at your ischium is kind of uncommon. I would guess that's your back. When you say your tailbone or that area hurts, I'm guessing you have a low back issue. Your ischium is where your hamstring's attached. So there's a bursa there, but it's not, unless you're doing a lot of hamstring exercise, I doubt it. So I'm guessing that's going to be your sciatic nerve. I think you have a back problem. If you tell me that in the office, you hurt in that part of your anatomy, almost always that's a sciatic nerve. Yeah.
I've heard that when it's in the groin, that's hip. When it's in the back or wrapped around or go down the leg, almost all of those are back problems.
Yeah, there's a lot of people have both, but that's the general rule. That'd be very true. There's a few back patients have groin pain, but groin pain would be more hip, and that pain you described down the leg, better talk to a back person first. Yes, sir.
Jeff, it's been a great pleasure to have you here. Thank you very much for joining us.
Thank you for inviting me.
And thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them.
If you fall and bruise your elbow, you'll probably be fine. But bruise your brain, and you may have long-term problems. Brain trauma, next time on Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota,
and with the ongoing support of these individuals and institutions, Brookings Health System,
Ophthalmology Limited,
South Dakota State Medical Association,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen Asthma and Allergy,
Black Hills Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Regional Health,
and Swiftel Communications.